Jet, sabihin mo sa akin kung mag-Zeiss videos mo.
Hello? Yes? Yes?
These days, we're all pressed for time, and I want to spend my time doing what is most productive. Let me show you how the Glaucoma Workplace from Zeiss helps me do this. The Glaucoma Workplace shows me an overview of all of my patients' visual field exams, so I can see any pattern of loss. The GPA helps me see whether my treatment is effective. I can set a new baseline after my intervention and monitor the rate of progression. When diagnosing new patients, the combined reports bring HFA and OCT information together in a concise way, with the problem areas flagged. This improves my efficiency and supports my clinical assessments, so I can spend my time where it counts the most, with my patients.
Okay, ready na po.
Good evening, everyone, and welcome to the PGS Glaucoma Roadshow. I am Rainer Kovar, and I will serve as your moderator this evening. This is the first of 4 lectures, which tackles basic concepts in glaucoma, from perimetry, gonioscopy, medical management, and laser treatment. These topics are must-know for general ophthalmologists, as well as to our residents who are busy reviewing for the coming OPEX. These sessions are being broadcasted in 2 different platforms, via PGS Facebook Live and through the PGS YouTube. So if you have friends who may not be able to watch this live, the lecture will be available at their own convenience. Of course, this event would not have been made possible without the generosity of Zeiss, our sponsor for this evening. To get things started, let me call in our PGS President, Dr. Manolete Delfin, to give his welcome remarks and introduction of our speaker. Manolet?
Thank you very much, Rainier. And good evening to our dear colleagues. Thank you for joining us tonight. Today, we start our series of webinars aimed for all ophthalmologists, residents, and fellows. We start with the lectures on the basics of glaucoma, which the members of the PGS developed, and our various members have delivered on our roadshow lectures in the pre-pandemic era, which seems so long ago. These lectures have been improved and updated regularly. And for the benefit of everyone, these lectures will be uploaded in the PGS YouTube page for all those who wish to replay or rewatch these lectures. Once the basic series of lectures have been delivered and uploaded, we then plan to hold on more personal discussions with our colleagues in all parts of the Philippines regarding their cases and difficulties in the management of glaucoma. If you have difficult cases or management dilemmas in glaucoma, and there are about in your chapter a lot who would like to join, feel free to contact us and we can arrange our virtual meetings with your group and our chapter society to help you all. I would like to thank the PGS members and the PGS board for their support in this endeavor. Thank you to Dr. Happy de Guzman for spearheading this project. And thanks to the PGS technical team with Dr. Rainier Cavar, Dr. Cesar Perez, and our new members, Dr. Gertrude and Dr. Paul Gomez, and a recent fellow graduate and hopeful member of PGS, Dr. Roel Villanueva. Thank you also to ZEISS Philippines, headed by Heidi Gomez, for sponsoring this premier webinar. So welcome everybody. Tonight, I'm also tasked to introduce our speaker. Our speaker is a dear friend and batchmate. She finished BS Zoology in UP Diliman as summa cum laude and valedictorian, and held the record for the highest general weighted average for over 30 years. She finished medicine at UP College of Medicine, graduating cum laude, and was also the class valedictorian. She took masters in molecular and biological chemistry at the University of Michigan's Medical School, graduating magna cum laude, and doctoral studies in the same institution with high honors. She finished her residency in UP-PGH and her fellowship in glaucoma at the Eye Referral Center under Dr. Manuel Agulto. She's presently affiliated with Asian Hospital Medical Center and Las Piñas Doctors Hospital. An accomplished pianist and singer, and she said if she had to do her life again, she'd want to be an award-winning actress. So we're giving Gigi her chance, her screen for her debut in the LED screen. So please welcome Dr. Gertrude Gwendel Baron Reinoso. Gigi, are you ready for your close-up? Thank you.
Thank you, Manolet, for that kind and wonderful introduction. Am I on?
Yes, ma'am.
Okay. Can I have my first slide, please? Good evening, everyone. I'm Gigi Baron Reinoso, and I will be talking to you about practical automated visual field interpretation. This is on behalf of the Philippine Glaucoma Society. Next slide, please. We'll have a short outline for this evening. First would be the basic principles, then I will show you a 6-step practical guide to interpretation. And then we will talk about monitoring progression. This is a basic lecture for our residents and just a review for our consultants. I have no financial disclosures. Next slide, please. The definition of the visual field, according to the International Perimetric Society, is the portion of the external environment of the observer wherein a steadily fixating eye can detect visual stimuli. Or paraphrasing, it's the part of the environment that a fixating eye can see. It extends 60 degrees superiorly, 60 degrees nasally, 75 degrees inferiorly, and 100 degrees temporally. The limits of the field superiorly are the brow, and nasally, the limit is the nose. Next slide, please. Perimetry is just one of the ways by which we can measure or map out the visual field. It's a measure of differential light sensitivity. This is the ability of the subject to distinguish a light stimulus from the background. In standard automated perimetry, there is a white stimulus on a white background. It is a form of static perimetry where stimuli are presented in random order at predetermined locations in the visual field. Next slide, please. This is Dr. Henry Tracker's island of vision. This is the most classic visual field representation. It is an island of vision in a sea of darkness. Like any island, it has its boundaries, it has its height, depth, and contour. Anything on the island can be seen, but anything outside or above the island cannot be seen. The island has a peak, or the point of highest sensitivity, which is the fovea. This is designated also as 0 degrees, or the point of fixation. The island has a well, or trough, about 15 degrees from the peak. This well extends from the surface of the island down to sea level. This is the area where there is zero sensitivity, known as the physiologic blind spot corresponding to the optic nerve head. Here, there are no photoreceptors, therefore no sensitivity. From the peak and going down to the beach or the shore, you will have a gently sloping curve downwards. That would signify the decrease in sensitivity from the fovea down to the periphery of the retina. In static perimetry, predetermined positions are tested from above the island. You would think of it like a helicopter with several landing spots on the island, and that would indicate the elevation or the sensitivity at that location. When you talk about kinetic perimetry, you talk about a moving stimulus that goes from the sea towards the island. You can think of it like a plane that is approaching the island at certain levels or altitudes and then landing, creating isopters. Next slide, please. Okay, so in this lecture, we'll confine ourselves to the gold standard, which is white-on-white perimetry or standard automated perimetry. It is a white stimulus on a white background. The stimulus size would usually be a Goldman size 3, but you can use a Goldman size 5 for low vision. The background illumination is in the photopic range, which is 31.5 apostilles. We use this to test the parvocellular pathway. The other automated perimeters are mentioned here just for completion. You would have the short wavelength perimetry or SWAP. This is a blue stimulus on a yellow background. The stimulus size is Goldman 5, and you are testing the coniocellular pathway of the retinal ganglion cells. The other one is the frequency doubling technology or FDT, which uses a flicker stimulus, which is actually an alternate grating. It uses the M cells of the RGC. Now, these other stimuli were developed in order to look for or detect early glaucoma, because in SAP, you may find them late. However, there could be some problems still with sensitivity and specificity with the newer automated perimeters, which is why it is still not the gold standard. Next slide, please. All right. Now, this is the blind spot when you see it in the perimeter or the printout. The blind spot is located around 15 degrees temporal to the fovea, and its center is about 1.5 degrees below the horizontal meridian. This diagram just shows you the different stimulus sizes and compares it to the blind spot. The size of the stimuli used to be measured using the angle of incidence. So if you will see here, there are degrees there, and that is actually That just shows you the diameter of the stimuli. Nowadays, we use millimeters squared. And we usually use the stimulus size 3, which is about 4 millimeters squared. Every jump in the size will be a four times increase in the area. So from 3 to 5 will entail a 16-fold increase. Because these stimuli are so tiny, surface defects can be adequately mapped out. Next slide, please. Now, the other principle we have to talk about is light intensity versus light sensitivity. When we talk about luminance, we're talking about intensity. No? This is the amount of light reflected or emitted by an object. It is expressed in apostilles. What is measured in perimetry is actually light sensitivity, which is expressed in decibels. Decibels and apostilles are inversely related. Decibels is a logarithmic measure and is a more intuitive number when we're doing our visual field. When only the most intense stimulus is seen, then light sensitivity is 0 decibels. So here at the bottom, you see 4,000 apostilles luminance, and their corresponding decibels is 0. Decibels can also be regarded as a measure of light attenuation. So look at it this way. When you have 0 decibels, you have 0 light attenuation. Therefore, you have full luminance or full intensity. The higher the decibel number, the less intense the visualized target, the better the sensitivity. On the average, a normal 20-year-old will have a sensitivity peak at 32.8 decibels. A normal adult will have a peak of about 31.5 decibels, and this decreases with age. Thus, the need for our age-corrected database. Next slide, please. Okay. Different machines have different threshold strategies. They are actually ways of approaching threshold. We call this bracketing. In full threshold strategies, the threshold is crossed twice or thrice using a step-ladder pattern with increments of 4, then 2, then 1 decibels. In the shorter dynamic strategies, you may cross the threshold only once, and you can have increments of 4 and 2 decibels or even 3 and 1 decibels. In the middle of this diagram, you have points 1, 2, 3, and 4. Okay, the first point to be seen by the patient is a supra-threshold point, which means it's bright enough to be seen by the patient. If the patient sees this and records a response, then the next step would be to make the stimulus less bright by about 4 decibels, going to point 2. If the patient records a response, then it will even become less bright, going to point 3, just to approach subthreshold or cannot be seen levels. In this case, once it cannot be seen, then you will have a reversal, which means that the stimulus will again be made brighter. But then you will use a smaller increment of 2 decibels going to 0.4. This is continued until you can cross it about twice in a full threshold. And threshold is defined as the value in decibels where the stimulus is seen only 50% of the time. Next slide, please. Okay, so going back to the island that we presented earlier, if one were to bisect the island passing through the peak to create a sagittal section, one would come up with the profile of the normal hill of vision. You would see the peak, the normal elevation, and the shape. In this slide, there is also an abnormal or pathological hill of vision. In this abnormal hill, you see that there is less elevation and there are valleys or potholes. Although the printout in the visual field will just show us numbers instead of the island, it's good to visualize it like this. Next slide, please. Okay, now the next question is, if the visual field extends to 60 degrees or beyond, why does SAP only test the central 30 degrees? Well, this is because no glaucoma, or well, in glaucoma, most defects are seen within the central 30 degrees, which is also known as Gerum's area. It is very rare in glaucoma to find a peripheral defect with central extension. Therefore, it's more efficient and more accurate to focus on the central 30 degrees. In more recent times, they have shown that a central 24 degrees is also a good screening test with the peripheral ring of the 30 degree omitted. For severely constricted fields, it would be wise to just test the central 10 degrees. Next slide, please. Okay. Let's compare the two most popular perimeters, the Humphrey Visual Field Analyzer and the Octopus perimeter. Illumination in the background is comparable between the Humphrey and the Octopus at a photopic range. Just an aside, in the old Octopus 123, they used the scotopic range and the illumination was just 4 decibels. But now they are comparable. Maximum stimulus intensity is higher in the Humphrey at 10,000 apostilbs and only 4,000 in the Octopus. Stimulus presentation time is twice as long in the Humphrey at 200 milliseconds. The decibel ranges are also different because of the changes in the luminance. 0 to 51 for Humphrey, 0 to 47 for Octopus. The names of the programs are also different. For the Humphrey, you have the 30-2 and the 24-2. For the Octopus, you can have the G1, G2, 32, 30-2. Because of this, the number of test points are different. 76 in the 30-2, 54 in the 24-2, 59 in the G programs with 2 phases. Even the presentation of the points to be tested are different. The spacing is different. In the Humphrey, you have a grid-like pattern with equal spacing at 6 degrees. In the Octopus, you have a radial pattern with unequal spacing of 2.8 degrees and more closely spaced stimuli in the central portion and greater spacing peripherally. For strategies, you have both full thresholds available, then CETA standard 4-2, CETA fast 3-1. For the Octopus, full threshold, G dynamic, and G top. Next slide, please. Okay, what test to order? There are so many tests, and you might want to know what test to order. Well, the full thresholds are the most sensitive, but they can be tedious because they will last for 12 to 15 minutes, and the patient will get tired. And because the patient is tired, you could have artifacts due to fatigue. Therefore, they came up with a more balanced modified thresholds that last half the time. And this is now the currently preferred method. You have the CETA standard. CETA means Swedish Interactive Threshold Algorithm. And then you have the Octopus dynamic. They are short, sensitive, reliable. Then you have the faster ones, like the CETA fast, and there is even a CETA faster. The CETA fast will last for about 4 minutes, the CETA faster for about 2 minutes. For the Octopus, you have the tendency-oriented program, or the top. These are very fast, and they are for low attention spans. If you cannot get a really reliable test using the threshold or the dynamic balance test, then you have no choice but to go to the fast tests. These are for children and very elderly individuals. Next slide, please. Okay, then you also have the low vision programs. These are for visual acuities that are less than 2200. You can have the Goldman 5 stimulus for the Humphrey and the low vision central program for the Octopus. These are also used for monitoring advanced glaucoma. If on the threshold or dynamic test, you see that the field is constricted to set to the central 10 degrees, then you may order the M2 or M1 test for the Humphrey or the 10-2 for the Octopus. They are really more sensitive centrally, and you can map out split fixation and central islands. They are very, very good because there are 68 points tested in just 10 degrees. So this is very good for severely constricted fields. Next slide, please. Okay, this is a sample Humphrey printout from one of my patients. Um, it can be divided into 6 groups or zones arranged in a counterclockwise fashion. Each part will be discussed in the next few slides. Let's take a moment to look at the 6 parts. So the first part will be on top. These are the patient and test details. The second part on the left upper, these are the reliability. Then you'll have the grayscale in the middle. Downwards, you'll have the age-corrected probability plots. And then on the right, you have the general indices. And on top of that, the special tests. Next slide, please. Now, the Octopus printout has a more roundabout way of printing things. However, they also can be divided into 6 zones, which correspond to those of the Humphrey. We will also discuss this later. Next slide, please. Okay, now how do you evaluate the visual field printout? So we're going now to part 2, all right? Reading an AVF printout should be done in a systematic, practical, and consistent manner. There are as many styles as there are readers, but this simple 6-step method, I think, will be helpful. The first would be looking at the general data and test parameters. Number 2 would be the reliability indices. Third would be the actual values and the grayscale. Fourth would be the age-corrected probability plots. 5, the global indices, and 6 special tests, which would be the glaucoma hemifield test in the Humphrey and the cumulative defect curve in the Octopus. Next slide, please. All right, so Zone 1, general data and test parameters. Pearls or tips? Look at the patient name all the time. They should be spelled correctly and should be exactly the same for all the tests you ordered for this patient. The birth date and the age should be accurate because you're going to compare them with the normative age match database. The date of the test should be accurate because you are going to monitor progression. For the pupil size, you should not have any extremes. Ideally, the pupil size should be 3 to 6 millimeters. Small pupils will cause decreased sensitivity and could have a field constriction. Large pupils can cause peripheral distortion as well as a decrease in sensitivity. Number 5, make sure that the proper refractive correction is given. In fact, when you order your perimetry, you are obligated to write down the refraction of the patient as well as the visual acuity. You need to correct the error of refraction. Why is this so? If you don't correct your hyperopia, you might find some problems or defects centrally. If you don't correct the myopia, you might see some defects that will mimic glaucoma. You should also add reading ads as needed because the working distance is 30 centimeters. Visual acuity should be indicated. If it is less than 2200, use the low vision or stimulus size 5. The type of program should be indicated and it should be appropriate and consistent. So here you really have to go down to the nitty-gritty and the details of everything. Next slide, please. Okay, zone 2, reliability. Is the test reliable? If it's not reliable, then it's not worth your time. You shouldn't even read it if it's not reliable. It's very important. Note that the test duration is important. If it's too long, if you were expecting a 7-minute test and it took the patient 10 minutes or even 12 minutes, then that could be an unreliable test. Maybe the patient had many rest breaks or paused the test in the middle. If you have a false positive error, which is high, or a high positive catch trial rate, then it would be a trigger happy patient and it would be unreliable. It should be less than 20% to be reliable. What is a false positive error or a positive catch trial? It's the error where the patient responds even if no light was presented. You see, when you take the test, there are clicks that you will hear, and sometimes the click will have a light, sometimes the click has no light. So if the patient is trigger happy, even if there was no light, he will press his button. For the false negative error or negative catch trials, this happens when the patient has no response to a bright stimulus at that same point where a dimmer stimulus triggered a response. This could alert you to an inattentive patient. However, when you have the edge of scotomas, when you test the edge of scotomas, there's a lot of variability, and this could contribute to a false negative error. Also, if a patient has very advanced glaucoma, then you might expect a large false negative error. Number 4, fixation losses. Okay, a fixation loss is measured when the stimulus is presented to the blind spot and the patient responds to it. That means that the patient moved his eyes or moved his head. A fixation loss rate of 33% or higher will be marked with a double X and is unreliable. The Humphrey field analyzer has a gaze tracker, which you might also want to check. I will show that later. The Octopus has a reliability factor or RF. This is measured with all the catch trials factored in, and it should be less than 15. Next slide, please. Okay, these are two examples of unreliable tests. On the left, you have a high false positive test. On the right, you have a high false negative test. The high false positive test is also called a white test or a white scotoma. You'll see white scotomas and you will see a reverse cataract pattern. What's a reverse cataract pattern? Well, in a cataract pattern, you will usually see more points depressed in the total deviation rather than the pattern deviation. In this reverse cataract pattern, you'll see more points in the pattern deviation and less in the total deviation. This is just an artifact of the statistical program that they used. Then, of course, if you look at the glaucoma hemifield test, then it will show very, very high sensitivity. Now, going to the false negative test, you will see the cauliflower pattern. Or I'm sorry, not the cauliflower, but the clover leaf pattern. I must be hungry. Okay. In the clover leaf pattern, you will see 4 points that have normal sensitivity. This is 1 point for each quadrant. So this is the area where the patient responded. However, maybe the patient was inattentive or tired and he failed to respond to all the other tests that were to the other test points that were presented to him. This could also be a problem for the first timers and could be due to the learning effect. Next slide, please. Okay. So this slide will just show you the position of parts 1 and 2 on the printout. So on the left would be your Humphrey printout, on the right your Octopus. So let's look at it one by one. You have the name, the laterality, which eye it is, the date of birth. Okay, then you'll have the test parameters. So on the left, you'll see a central 30-2 test there, stimulus size 3, which is white. Then you will see the pupil diameter, which is 4.2, which is acceptable. A background illumination of 31.5, strategy of theta standard. Visual acuity was not written here, but the refraction given was written there. Then, of course, number 2 would be reliability indices. The fixation monitor, fixation losses, 1/19, acceptable. False positive errors, acceptable at 5%. False negative error, acceptable at 6%. Test duration, acceptable at 7 minutes. All right, so below that is the gaze tracker. So the gaze tracker shows you when the patient lost fixation by showing you an upstroke. The downstroke is the point when the perimeter did not see the pupil of the patient. So that's probably when the patient blinked. On the right, you will see the octopus printout. So on the upper part on the right would be the patient data. And then below that, you would see the test parameters also. For the reliability, would see catch trials. So catch trials positive is 1/7, which is 14%, still acceptable, and 0 out of 8 for the negative, which is 0%, very acceptable. Refraction is indicated. The pupil is acceptable at 5.36. Duration, 4 minutes, acceptable. Here you also have the reliability factor, which is 6.6, which is acceptable. Next slide, please. Part 3 or zone 3 would be the grayscale or actual values. We try not to look at this really because it's not helpful to us and it may sway us. But it might be useful because of the wow factor in explaining the results to the patient. Please don't use this for interpretation. Okay, do we have to look at the actual values? Well, not all the time. However, you might want to look at the actual values in the presence of rapid deterioration, sudden field changes, extremely high or extremely low values. Next slide, please. Next slide, please. Okay. Zero in on the age-corrected probability plots. That's our mantra. Okay. This consists of two parts. The generalized plot on the left and the focal plot on the right. In the Humphrey, it's called total deviation and pattern deviation, respectively. In the Octopus, it's called probability and corrected probability, respectively. The total deviation and the probability plots on the left will show points with generalized decrease in sensitivity regardless of the cause. So this can be due to glaucoma, this can be due to errors of refraction, this can be due to media opacities. The pattern deviation as well as the corrected probability plots will be more specific for glaucoma and will show defects which are important. Next slide, please. Okay. The age-corrected plots are the results of comparing the patient's sensitivity with a normative database of the same age group. The general plots will point towards the height of the hill because these are total defects. The focal plots, which are the pattern deviation and corrected probability plots, will take away the generalized component to accentuate the shape or smoothness of the hill, pointing to focal defects. You can think of it like a bulldozer. Okay, you have the hill with a total deviation or probability plot. Then you run a bulldozer through it, removing the topsoil. And if you remove the topsoil or all the loose soil, then you can reveal the potholes and the valleys. Okay. Next slide, please. All right. Comparing total and pattern deviation plots will actually allow us to determine if the defect is a generalized depression only, or if it is a focal defect only, or if it is a combined defect. All right. Also, if you look at the plots, you will be able to see that there are corresponding p-values, right? There will be p of greater than 5%, less than 5%, less than 2%, less than 1%, less than 0.5% per point. The p-value will tell you the probability of this point being just due to a random occurrence. Now, the lower the p-value, then the more statistically significant this point is, and the more depressed or dense this defect will be. Next slide, please. Okay, on the left lower, you have a patient with a cataract who is also glaucoma suspect. On the right upper, you have a patient with a focal defect. Okay, for this patient on the left who has a cataract, you will see a lot of points in the total deviation, but just a few scattered points on the pattern deviation. This is the effect of the media opacity. Now, on the right, you will see a purely focal defect. And if you look at the total deviation and the pattern deviation plots, they will be similar to each other. Next slide, please. Okay, so you have these plots already, and you want to find out if they are significant and if they are glaucoma. Now, these are the criteria. I'm sorry for the typo. 2 was typed twice. Okay, this is based on the Anderson-Hodap automated perimetry criteria. Just looking at the pattern deviation or the focal plots, first, you should have a cluster of 3 or more depressed non-edge points with p-value less than 5%. And of these 3, at least 1 point should have a p-value of less than 1%. Or you can have a deep focal defect that's less than 3 in number, but they should be found in certain critical areas like the nasal step, the temporal wedge, or the paracentral area to be considered glaucomatous. Second, you should follow the retinal nerve fiber layer pattern, which is usually an arcuate pattern. 3, it should respect the horizontal meridian. And 4, it should be reproducible in subsequent tests. Next slide, please. Okay, these are the common glaucoma patterns. Please don't look at the grayscale. Let's concentrate on the probability or the focal plots, okay? The first would be the nasal step, okay? This is a very, very early glaucomatous defect, okay? Then the second one would be the paracentral defect, which is also an early defect. The temporal wedge is a rarely seen defect and would arise from the nasal retinal nerve fiber layers which would actually enter the optic nerve in a radial manner. The temporal wedge defect can sometimes not respect the horizontal meridian. Then you can have an altitudinal defect, which would be quite advanced. However, when you see an altitudinal defect, you should be able to differentiate this from other non-glaucomatous illnesses or problems like the AION, or anterior ischemic optic neuropathy. The most common defects would be the arcuate defect, which would correspond to the distribution of the retinal nerve fiber layers. Now, in the advanced defect, you can have uh, a combination of all these. And so it would really look constricted. You can have a large nasal step, upper and lower. You can have large arcuate defects, upper and lower, leaving you with a central island or even just a small temporal island. Next slide, please. Okay, part 5 would be the global indices. Here you have the global indices for the Humphrey and the Octopus. There's a slight change in nomenclature. MD is mean deviation. PSD is pattern standard deviation. SF is short-term fluctuation. CPSD is corrected pattern standard deviation. For the Octopus, you have an additional index, which is MS, mean sensitivity. Then you have MD as usual. LV is loss variance, which will show you focal defects. CLV is corrected loss variance. SF is the same, short-term fluctuation. And sometimes the RF is also located here. Next slide, please. So just tackling this one by one. Average sensitivity is MS. The Octopus has it. Average deviation from age-corrected normals would be MD. This would be taking the values as a whole, all right? And this is not just an algebraic mean, actually. It is a weighted mean, which means that central points have more weight than peripheral points. The normal values are plus minus 2 for both. If you're talking about focal defects or defects in the shape, then you talk about pattern standard deviation or loss variance. Now, why do you say this? Because this is when you compare a certain point with its neighboring points. And if there is a large gap or difference, then you say that there is a large standard deviation among the points. They should be equal or less than 6. For intratest variability, when retesting points, you talk about short-term fluctuation. This is when the patient actually reacts to the same stimulus at the same point, but in a different or in a variable manner. The normal short-term fluctuation should be 2. Now, when you get your corrected PSD or corrected LV, it's just PSD or LV minus SF. And it should be 4. Now, let's make it easy for you. We don't really have to memorize all these values because the perimeter will tell you if the value is abnormal by presenting the value with its corresponding P value. So if you see a number with a corresponding P value, then you know that you are looking at an abnormal number. Next slide, please. All right. Part 6 would be the special tests. The Humphrey has the GHT or glaucoma hemifield test and the VFI or the visual field index. First, let's tackle the glaucoma hemifield test. 5 zones based on the retinal nerve fiber layer pattern in the superior hemifield are compared with their mirror images in the inferior hemifield. 1 would be paracentral, then 2 is above 1, 3 is the nasal step, 4 is above 2, and 5 is temporal to 4. All right. The GHT readings can be abnormally high sensitivity, within normal limits, borderline, generalized reduction of sensitivity, and outside normal limits. Now, the VFI is expressed as a percentage of the normal function and ranges from 0 to 100%. It is used in many studies. because it is not influenced by diffuse field loss. It's not so much influenced by EOR or media opacity. And it's very much used now when we monitor progression. Next slide, please. Okay, the octopus cumulative defect curve is also called the BB curve, named after a Swiss ophthalmologist. All right. There are actually four things that you can see here, but before we look at it, we'll just say that the points are ranked from most to least sensitive regardless of location. So this is just a ranking from left to right. All right. So if you have a normal field, then the defect curve will be within the normal band or range. If you have a diffuse defect, the curve will be parallel to the normal, but at a lower position or a downward shift. If you have a localized defect, you can really just start with a normal looking curve, then suddenly it drops down as you go to the right. If you have a combination of local and diffuse, then you will see both a downward shift and a drop as you go to the right, as you go slanting very steeply downwards. Next slide, please. Okay, so you have seen all these parameters, these criteria. Now let's synthesize or summarize it. Is this a glaucomatous defect? There are three minimum criteria for glaucoma defects. This is based on a full threshold field using the Humphrey field analyzer. One, we talked about this, all right, the pattern deviation plot. 3 or more points not on the edge with P less than 5% and 1 point having a P less than 1% clustered in an arcuate area. We also talked about the exceptions to the rule about the critical areas where you could have less than 3 points. Then we'll go to the CPSD or PSD, corrected pattern standard deviation or pattern standard deviation. The value should be abnormal with a P of less than 5%. Then the third criterion would be an abnormal glaucoma hemifield test. Next slide, please. All right. So these are from my patients. Okay, on the left, you will see, well, an abnormal printout. There are defects right on the edge, right around the visual field. And if you look at the density or the depth of the defects, they are very, very deep with a steep drop off, a very deep defect, and then suddenly beside it, a normal looking point. So this would raise a red flag, and this would make you think maybe this is a rim artifact. So what we did was put the trial lenses closer to the eye, and we did the test again. And lo and behold, the test was normal. On the right side, we had an elderly patient who, I don't know if she wanted a blepharoplasty or not anyway. Again, you see a peripheral defect, very, very steeply sloping, very abrupt. And when I looked at the patient, she had ptosis. So we taped the lids, did the fields again, and it was a normal field. So beware of artifacts. Where can you also see some artifacts like this? On the left, you can see an artifact like this when you have a small pupil or a very deep set eye. On the right, you can have an artifact like this when the brow is very, very prominent. Next slide, please. Okay. When evaluating the visual field defect, one also, of course, must look at the retina to pinpoint where the corresponding defect should be. You should look for retinal nerve fiber layer thinning or dropout as well as look at the optic nerve rim for any abnormalities. Structure function correlation is very, very crucial. On the first one, you will see a paracentral defect, and you would expect a retinal nerve fiber layer thinning very, very close to the fovea or the macula, which is actually inferior in location. If you cannot find that using the red-free photo, then trace it backwards to the optic nerve rim, and you might see either a notching or maybe thinning or maybe bayoneting on the optic nerve rim. In the middle, you will see a classic superior arcuate defect with threat to fixation. There could be split fixation here. So when you trace that, it should be in the inferior retinal nerve fiber layer, which will cause this problem, and it can also be traced to the inferior optic nerve rim. On the right, on the third field, you will see a classic nasal step, which is inferior, and so you should look at the superior RNFL, more peripheral to the fovea and the macular area. And you can also trace that eventually to the optic nerve rim. Okay, next slide, please. So the next question is, okay, there's a defect. So how bad is it? How advanced is your glaucoma? Because this will tell you how aggressively you have to treat your glaucoma. Okay, for the early defect, you look at three parameters: the mean deviation, the pattern deviation plot, and the central 5 degrees. For early, the mean deviation should be less than 6 decibels. For the pattern deviation plot, okay, you might have to count, but I don't like counting, so you can just eyeball this, no? Points less than 18 in number with p-values less than 5%, and of these, less than 10 will have a p-value of less than 1%. Looking at the central 5 degrees, there should be no point less than 15 decibels. For moderate, the mean deviation should be from 6 to less than minus 12 decibels. And then the points would be less than 37, P less than 5%, and less than 20, P less than 1%. If you look at the central 5 degrees, there should be no point at with 0 decibels. And only one hemifield should have a point with a value of less than 15 decibels. For advanced, MD should be greater than minus 12 decibels, points greater than 37 with P less than 5%, and greater than 20 with P less than 1%. There could be a 0 decibel point in the central 5 degrees, and both hemifields in the central 5 degrees can have points with less than 15 decibels. Next slide, please. Okay, now let's go to the last part, monitoring glaucoma progression. So how do you monitor progression? Well, first of all, you have to get as many baseline fields as necessary. Can be 2 or more, can even be 5. There are people who are really poor test takers, and every time they have a field, it's different. So the result should be reliable and reproducible. How do you do this? Sometimes people are poor test takers when they use an Octopus. So you might want to make them try a Humphrey. Or sometimes they are poor test takers because of the eye center or because of the technician. So you might want to change the eye center or the technician. The result should be reliable and reproducible. That can be a baseline field. You should confirm progression in at least 3 tests. The new modalities now will require 5 to 6 tests. You compare tests only if they have the same strategy or program. So what are the signs of glaucoma progression? Well, first, if you have an existing defect that has become wider or bigger, or if you have an existing defect that is deeper or denser, or if you have a completely new defect, that is the sign of progression. Next slide, please. Okay, this is the Humphrey glaucoma progression analysis. So many ophthalmologists don't even look for this, or they don't even request this, which is a pity because it's free. If you have enough visual fields for the patient, you can ask for this. Okay. Looking at it, you will have two things that are striking. One is a trend analysis in the middle, where you plot your visual field index with the age of the patient, right? And you can even extrapolate this plot to the next 5 years. So you can see the deterioration of the visual field of the patient. The slope is significant if you see a p-value of less than 5% or less than 1% or even lower than that. The rate of progression is also indicated. Then you have an event analysis on the lower right-hand side or lower right-hand corner, where individual points are compared with the baseline and with 2 or 3 previous tests. And the significance is indicated here in this legend. You have variously shaded triangles, a clear triangle if there is deterioration from the baseline test, a half shaded triangle if there is deterioration based on compared to 2 consecutive tests, and a fully shaded one when when it's deterioration based on 3 consecutive tests. Now, what are the other tests that you can see here? The first 2 tests on top would be the baseline. The last test, the one at the bottom, would be the latest visual field of the patient. So if you look at this test, you will see significant deterioration, not only in the visual field index, but also in the points tested, and significant constriction of the field. The rate of progression of this patient is about 3.1% per year, which is quite high. Most glaucoma patients, when they're treated, will have a 1 to 1.5 deterioration per year. Next page, next slide, please. This is the Octopus progression analysis. It's very, very similar. You'll have the global trend analysis where they plot the mean defect and per year, and they look at the slope. They also have the loss variance line, and they look at the slope of that. And if you see an arrow head, which is colored red, then that means there's a significant depression or significant decline. The areas tested will also be correlated with the RNFL zone. So you have the corrected cluster trend analysis over there. On the right hand, upper right hand, you have the polar trend analysis, where you will correlate the deterioration or the defects with the optic nerve rim. The last part would be the OCT, which should correlate with all the other defects that you monitored. Next slide, please. Okay, we cannot overemphasize the need for clinical correlation as well as structure-function correlation. One should not evaluate or treat the patient based on the visual field results alone. So for example, you have this patient, you have a paracentral defect. Then if you had a red-free photo or if you have an OCT, then it would be nice to show the structural basis for this defect. And If you have this photo like what we have here, then you will see the notch, which would correspond to the defect that you see in the visual field. Next slide, please. Okay, so we're at the last slide. Practice makes perfect. How do you do that? Hone your visual field reading skills using an atlas. There are so many free atlases online, and you can practice. Number 2, prepare your own official reading for each patient. Do not rely on what is given you. Sometimes they can be wrong. Number 3, remember the acronym PRACTICE. Practice means P for parameters, R for reliability indices, age-corrected plots would be A, T for tests, I for indices, the global indices, C for correlation, structure-function correlation, E evaluation or clinical evaluation. Practice makes perfect. Lastly, I would recommend that you experience an actual automated perimetry done on yourself, or at least observe one being done to your patient, so you know how it feels. Thank you for your kind attention.
Thank you very much, Gigi, for an exhaustive lecture on perimetry, even comparing results of the Humphrey and Octopus. I'm sure our viewers will appreciate this lecture even more because they will be able to relate to the perimetry results that they have. Let me remind everyone to please fill out the feedback forms posted in YouTube and Facebook chat boxes. This will serve as attendance for this session. So let us now proceed with the question and answer portion. For those of you with questions, you may still post them in the chat boxes in the platform you are watching from. So for our first question, what are the limitations of the standard automated perimetry?
Okay, well, of course, there's the cost, all right. Number 2, not every center has it. But aside from that, it's a subjective test, all right? So it will depend on how well the patient responds to the stimulus. It's not an objective test. Therefore, if you have a poorly performing patient, then the test will not help you at all. There are other objective tests like the visual evoked potential, which will actually give you more results without depending on the patient. Number 2, it is based on an age-related database. Most of the databases will start at 12 years old going upward. So when you have extremes of age, then you might not really have a very, very good comparison. It's known, there are studies that show that children between the ages of 4 to 12 when still have very, very variable fields. And some studies show that the fields can expand as the child approaches 12 and then become stable at 12 years old. So those are the limitations. Well, aside from the other, the third, I think, biggest limitation is it's a relatively late test, right? So you can have substantial damage already to your RNFL and your optic nerve, even 30%, 40% before you can see a defect in your visual field. And that's why they came up with other programs like the SWAP and the FDT.
Thank you very much, Gigi. For our succeeding questions, we're lucky to have Manolette and Happy with us in this panel, Gigi. For our next question, can you improve your visual field? And what do you advise our patients to do prior to having their tests done? Anyone can answer.
Yeah, anybody? Okay, can you improve your visual field? If you have a defect, a structural defect, of course you cannot improve your visual field because the retinal nerve fiber layer cannot regenerate, the retinal ganglion cell cannot regenerate. However, maybe you can say you can improve your visual field by being a better test taker, and that's due to your learning curve. Maybe your first first the test was a really, really bad test, and then you learn how to do it. You know how to avoid your false positives and your false negatives. You can keep your eyes more steady, and you know what to expect. Then, of course, your fields will have a better result the next time, and that's the importance of a baseline.
Manolet,
Um,
what do you advise your
Yeah.
patient prior to having the test done?
Well, I explained the procedure with them, no, because a lot of these patients, syempre they want to make good in the test all the time, so their eyes are moving around and all of that, so that makes for a unreliable test. So I advise them to always what will be happening during the test. They're very apprehensive actually. Before, when the test used to take over 15 minutes long, that patients never really wanted to take the test. But now with the faster programs, it's easier for them to do it and they feel better. But just long as they know what they're getting into. And then I always tell them that the first test is never really the most reliable test, so that we might have to repeat it. And usually we do have to repeat the test to make sure to make a good diagnosis of the, or to get better reliability in these cases.
And of course, usually our patients are, if they're doing it for the first time, they're very eager and excited. They seem to want to press every time. So
Yeah.
sometimes even if very, very faint sound, they will press on it. So sometimes it helps to tell them that they won't be able to see all the light no matter how faint it is, because it's designed that way now that they can see all the light every time.
okay,
And I
but
think we
there's
have to tell
another.
our technicians also that they have to watch the patient, because some of them just put them on the machine, then go out and come back after a few minutes, and so they have to keep on watching the patient and keep on reminding them to look straight, and because they have to reassure the patient also in this case.
Can I
I
say something also?
Yes, Gigi.
Me?
Yes.
Okay. Um, there are patients who have dry eye and they blink a lot. They feel very uncomfortable. So what I say is, if you want to blink, blink at the same time that you press the button, so that you won't have that blink artifact. So when you press the button, blink also. Okay.
Great
And
suggestion.
um
Wanted to say
I
something.
I like to tailor my response, my advice based on the patient's previous field. So if the patient's last field showed a lot of false negatives and artifacts that I think are due to fatigue, I tell them, okay, on the night before your test, make sure you got enough sleep. Try to schedule your test at a time of day when you're most awake. If you need to drink coffee, drink coffee. And then if the patient's last test was full of false positives or um, fixation losses, then that's when I tell them the advice about you're really not going to see every test. So try, don't base your responses on what you hear. So you're not really going to see every stimulus. So don't press the button if you didn't see it.
Excellent points. So our next question is a 0 decibel value equivalent to blindness?
No, it's not. Okay, people might think that 0 decibels means you didn't see anything. That means it's blind. No, it's dependent on the most intense stimulus. So 0 decibel just means you didn't see the most intense stimulus, whether that would be a 4,000 apostille stimulus or a 10,000 apostille stimulus. That does not necessarily mean that you are blind in this area.
Okay. And next question, can PSD become lower?
Yes, yes. The PSD can become artificially
or
lower.
negative.
It can be or negative. When does this happen? Kasi PSD is a measure of variability or uniformity. So when you have points that are very different from each other, for example, you have early glaucoma or even moderate glaucoma, then your PSD can become high, right? But as you go into your advanced glaucoma and you have really, really dense defects and these fields, the points are really dense, then of course the uniformity, it will become more uniform, but uniformly bad, right? And so your PSD can actually become lower artificially.
Okay. Our next question is, how do you monitor the visual field of a glaucoma patient who subsequently develops another ocular condition or undergoes a cataract surgery?
So you have to set a new baseline after the patient develops that condition or undergoes surgery. Not necessarily cataract surgery, but even a trabeculectomy. So you start you tell the technician manning the perimetry machine, okay, when you input the fields that we will include in the analysis, like in the GPA for the Humphrey, you start at this point. So you have to coordinate really well with the technicians in the eye center.
I agree with Happy. Actually, when you do the progression analysis, you have the it's up to you to determine what your baseline will be. So even if not just having surgery or having an ocular condition, like adding a new set of eye drops, you have to set your baseline again. And so you can do that manually. Again, like Happy said, you have to coordinate well with the vision center so that they can set their reset your baselines.
Gigi, any additions to those comments?
Yeah, just the point of this question is basically you have to establish a baseline again. That's just it, because it's just like having another eye again. Just it's a totally different eye right now with a different set of parameters. So that's how you do it.
Excellent, excellent. Okay, you have a few more questions to go. Say you have a patient who undergoes cataract surgery and opts to have a multifocal IOL. You think this will affect his perimetry result? And of course, we don't need to put any adds to his refraction in the perimetry monitor, right?
Okay.
Um,
Go on. Happy. Go on.
so most multifocal IOLs, especially the older ones, they tend to give a little bit of decreased contrast sensitivity. So perhaps the the mean deviation or mean defect might go down just a little bit, but other than that, it shouldn't affect the results of the perimetry.
There's a study from the Netherlands by Acheus. It's ophthalmology JMA JAMA, which shows that multifocal IOLs will decrease the mean sensitivity by about -2 decibels. And they compared that with a monofocal and then a phakic patient. The monofocal and phakic patient will just have something like a -0.3 decrease in mean sensitivity. And they attribute this to the design of the multifocal. If you notice, when a patient wears a multifocal, the patient needs a lot of light to see near. See, because the light beam is actually split into the different parts of the IOL. Therefore, you really expect a decrease in beam sensitivity or a more negative mean deviation.
Yes, if I remember correctly, usually aspheric IOLs will give you at least 8% decrease in contrast sensitivity, whereas multifocal IOLs will give you around 12% loss in contrast sensitivity. So that's at least 4% difference from aspheric to multifocal IOL.
So would you place ads?
No need to place ads, right? But some centers still do. So I think it's important for the requesting doctor to place if your patient has a multifocal IOL when you're putting the requests for your perimetry test.
So
So
I think oh sorry. So I think one of the take homes from this webinar is that your requests to the technicians at the eye center should be detailed. Put the ad if they need an ad. Put the where to start. Ask for a GPA or a similar progression analysis in whatever's the software of your machine, and be detailed about when to start the which dates to use in include in that analysis.
I, I agree with that. No, that the one of the key people in this whole practice is our technicians. So I personally hate it when I see a patient come back with perimetry results who has a severe generalized depression and all you can see are black spots all over. And it's hard to tell the patient to go back to the eye center to have the test repeated with a 10-2 or a low vision mode at that point. So if it's the first test of the patient, I sometimes just have to put in 24 or 30-2 with a 10-2 because I'm not sure if I'm gonna get strict fixation on this patient or not. So if you have a good
Yeah,
technician who would know, then that's great.
yeah.
But well, it differs
Um,
centers. Yes, Gigi.
yeah. Let me just say that you're also only as good as your request. So if you like just give a request to the patient and say for perimetry, you're not gonna get a good perimetry. Okay, so you have to write there what test you want. Do you want a 30-2, a 24-2, a 10-2? Uh, you have to write there the refraction. That's as the referring ophthalmologist. You have to write the refraction. You have to write the visual acuity also. So you're only as good as your request. If your request is lousy or you're lazy in putting in your request, then of course the perimetry result coming back to you will also be lousy.
Yeah, that's true, Gigi. You're only as good as a request, and the readings will only be as good as your request because otherwise the readings would be so generalized. You probably want to cannot commit to anything if your request is just as vague.
Okay, excellent. I don't think we have any more questions at this point. So again, let me thank Gigi for an excellent lecture. And I would like to thank our panelists, Manolet and Happy, for chiming in. Truly, this made perimetry more understandable and practical for all of us. So at this point, let me call in our friend from Zeiss, Mr. Mike Morales, the Regional Product Manager, for a few words. Mike?
Uh,
Mike, you're still on mute. Mike?
Okay. Can you hear me?
Yes, Mike, go on.
Yes, doctor. Thank you very much, Dr. Kumar. And first of all, we would like to thank everyone for attending this very informative webinar. For more than 30 years, the Humphrey Field Analyzer, or the HFA, has been the accepted standard of care in glaucoma diagnostics and management globally. The new HFA3 upholds the Humphrey tradition of accuracy. Test results on the new platform are equal to the interchangeable with results from prior generations of the Humphrey Field Analyzer, providing continuity and certainty in the ongoing care of patients. The HFA3, together with the other components of Zeiss glaucoma management offerings like the Cirrus OCT and Forum Glaucoma Workplace, delivers an unrivaled combination of seamless integration and diagnostic performance to the eye care professionals who diagnose and manage glaucoma. In behalf of Zeiss Philippines, we would like to thank the Philippine Glaucoma Society for organizing this event. And one more thing, should you need a free soft copy of our Effective Perimetry HFA Primer 4th edition ebook, please feel free to contact any of our Zeiss representative. That's all, and thank you very much.
Thank you very much, Mike. Thanks to ZEISS Philippines for continually supporting PGS activities. Now to give us our closing remarks, let me call in the PGS Vice President, Dr. Hannah de Guzman. Happy?
Thank you, Rainier. Good evening to everyone. I'd like to thank our audience on YouTube and Facebook for taking your time, spending an hour with us, an hour and a half with us this evening. I hope that you have learned enough to things that will help you in your daily practice in the future. Um, of course, I must thank our expert on perimetry, Dr. Gigi Reinoso, for a very, very informative, great talk, Gigi. I'm already a glaucoma specialist, and I still learned a few more things tonight. So thank you, Gigi. Of course, thank you to ZEISS, our sponsors for this evening. We couldn't do this without your help. And most especially, I'd like to thank the PGS members who helped bring this event to life, who especially the technical team. So it's not just PGS members, but also hopefully PGS future members. You've done an amazing job this evening, and I really appreciate how much effort has gone into making it a smooth and seamless webinar and webcast to YouTube and Facebook. So I hope to see everybody next Tuesday, and thank you for listening.
Thank you, Happy. And we hope to see everyone in our next 3 lectures on Tuesday, September 22, on Friday, September 25, and next Tuesday again on September 29. We have 3 more roadshows to bring to our members and to our residents. PGS also has a special session with the PAO on September 24 at 8 a.m. with the President of the American Academy of Ophthalmology, Dr. Ann Coleman, on the AAO's response to COVID-19. That should be interesting to watch. So all good things must come to an end, and we formally bring this session to a close. Again, I would like to thank and acknowledge our IT team, composed of newly accepted members Jet Rael and Paul Gomez, and handling the PAO side, Roel Villanueva. Thank you to everyone for tuning in, and stay safe. Good night. Thanks, Gigi. Thank you.
Thank you, ma'am.
Thank
sir.
you, Gigi. Thank you,
Thank
Jet,
you.
Paul, Roel.